I'm Dr. Koen Deloose. I'm the head of the Department of Vascular Surgery in AZSint Blasius Hospital in Dendermonde, Belgium. And I want to discuss today with you the PRIZER study with the Renzan stent. Yes, right up to now, I think that the accent is most on drug-eluting technologies. So I was asking myself, is there in 2022 still a place for a modern generation of bare metal stents? And if you are looking carefully to the literature and you are listening here on this Congress to the presentations, you see that, for instance, when you are using drug-coated balloons in very complex lesions, that you need a high rate of bailout stenting with bare metal stents. On the other hand, we learned yesterday also something about the local toxicity of the potential local toxicity of paclitaxel. So in some indications, some situations, potentially it's better to use a bare metal stent. And so based on this, I think there is definitely place, a need for modern generation of nitinol stents, bare metal nitinol stents. So the Renzan stent is actually a stent design that is based on the success of the road saver carotid stent of Terumo, with some adaptations at the flaring ends, the lengths, the delivery platform and whatever. We are facing today a bare metal stent, a dual layer micro mesh stent. So there is an outer layer that is an interwoven stent design, but there is also an inner layer with a micro mesh design, also interwoven mesh of nitinol. And so the combination of both is, in my opinion, a step in the good direction. First of all, very interesting, it is protecting against distal embolization. I noticed that more and more people, also during PAD treatment, they are using distal protection devices, filters. Well, with this stent, the stent itself is actually a protection device. It is a monorail system, 6 French compatible, 018 guide wire system. It has some flaring ends proximally and distally, and in terms of visibility, the stent is doing a great job because there are 3 tantalum markers at the flaring ends, proximally and distally, and there are also 2 tantalum markers on each side of the micro mesh. So visibility is perfect. When you are looking at the radial forces of the stent, it has sufficient chronic outward force, not too much, not to create intimal hyperplasia. But on the other side, we see that in terms of radial resistive force and crush resistance, the Renzan stent is doing a great job, better than the majority of the competitors. So the study design, the PRIZER study, is actually a prospective, non-randomized, single-arm, multicenter trial where the Renzan stent is going to be investigated in 135 subjects. 90 patients will be enrolled in a fem-pop arm, and another 45 patients will be enrolled in an isolated popliteal artery disease cohort. And so the follow-up time is 36 months. The primary endpoint is on one side in terms of efficacy, primary patency at 1 year based on duplex ultrasound findings. And on the other hand, we have also a safety primary endpoint looking at major adverse events, TLR, amputation rate and death. So right up to now we are enrolling in this PRIZER study. There is 40% of the enrollment completed right up to now. What do I expect at the moment, as I am one of the most important enrollers in the trial? My gut feeling is very good. What I've seen, the controls at 30 days, at 6 months are really looking great, and so I'm quite comfortable. Unfortunately, I can even not compare with other bare metal stents due to the specific design of this Renzan stent. It's uncomparable. I'm really curious to see if the results are at least in the area of drug-eluting technology results. And that's also for me an open question mark for the near future.